So these are my disclosures. Well, I won't go through the natural history. You've already heard that. But when I speak to a non-clinical audience, I do need to show NAFL and NASH, briefly explain the difference. But if I take us a little bit out of the clinical world and into the policy world, they really don't see or even understand very much the difference, other than that it's worse to have NASH than it is to have non-alcoholic fatty liver disease. So I use this to basically explain the situation and sort of where we are in the progression in the liver. And we've already heard that NAFLD-NASH is a multisystem disease, and that's what we'll be focusing on the rest of the meeting. This is extremely important when speaking to policymakers, to decision makers in the health system. And as I'll go on to explain, if we focus just on NAFLD-NASH and explain the very high prevalence, the possible severity and health outcomes of having NAFLD-NASH, it might not be enough for a very long time to get policy change onto the agenda. So we do need to explain the interaction with obesity, cardiovascular disease, diabetes, CKD, etc. We heard the prevalence, and I'll report it here as well, as being around 25% of the adult population. There are a lot of questions around these prevalence estimates, and similar to hepatitis C, which lowered the prevalence by over 50 million just 4 years ago. I think we're going to see as studies get more advanced, as methodologies get more refined, and we already know that the Global Burden of Disease Collaboration is working on a new paper, we'll probably see that 25% estimate come down. That doesn't mean that 10 or 15 or 20% of the world's adult population won't have NAFLD-NASH, but the numbers will probably come down a little bit, and I expect there to be a new study out in early 2020 shedding light more specifically on what we think the adult prevalence is. There's a huge difference between regions, gender issues, age issues, and of course a much higher prevalence among risk groups, particularly those with diabetes or obesity. So the HepaHealth study from a few years ago took a look at what is the burden of liver disease across Europe. And when you look at the red for NAFLD-NASH, in some countries you can't even see it. And this goes back to what Emmanuel was saying around the low numbers of people who are actually coded for having NAFLD or NASH. What I would draw your attention to here is the orange part of the bar. And even here on the far right, in a country like Romania, where the majority of cases are reported as unknown. So we see huge variation between countries, but common for them all is that at least a third, sometimes even a half of the cases are reported as unknown. You can look this up in EASL's HepaHealth report or the published article. What we think is that a lot of that unknown is actually NAFLD-NASH, since we are reporting alcohol and viral hepatitis. It's just not been coded properly. And this is one of the big issues and one of the areas where we need to improve the training really of all clinicians to make sure NAFLD and NASH are properly coded. So I mentioned that I'm on the board of the EASL International Liver Foundation. And a few years ago, we took on as one of our priority issues raising awareness and improving education around NAFLD-NASH, largely from a non-clinical perspective. So really everyone else except for more or less the people in the room. But I still think it's important for you to be aware of the policy scenario around this condition. So the question was really to evaluate the extent to which European Union member countries have key policies and guidelines in place to address NAFLD-NASH. This will become increasingly important. One, as awareness increases. Two, as treatments become available, as the public starts to realize that this is an issue that can affect them. We wanted to identify the gaps and opportunities for improvement in NAFLD-NASH policies and guidelines and mobilize follow-up action, including an international coalition. The stakeholders involved in NAFLD-NASH are not organized. beyond the immediate liver field, there's very little awareness. That includes other patient groups, diabetes, obesity awareness groups, and so on. So the thinking is that we need, the same way we've done in HIV, hepatitis, cancer, and many other areas, to strengthen the community groups, to strengthen the patient groups, and bring them together with clinicians, but also experts in global health, health systems, health policy, to start to really drive this agenda forward. So we conducted this study in 30 countries. The focal points for reporting on the survey that I'm going to explain in a moment are listed here. The first, Dr. Razzio, will be chairing and speaking tomorrow, and you've seen Matthias Eckstedt cited many times. Manuel Romero, of course, is here, and so on and so forth. So we asked experts in the countries to follow a questionnaire that we prepared with them and for them in order to, based on document review, inform us of the policy scenario in their particular country. If anyone knows someone from Malta, let me know. They were the only country in Europe that did not respond. And the first question we asked was a very simple one, and this was based on the work we had done in HepCor with the European Liver Patients Association on hepatitis B and hepatitis C. We said, does your country have any written national or regional NAFLD-NASH strategy or action plan? So of 29 countries, what do you think in the audience? How many had a written national or regional plan? Well, none. And it wasn't a big surprise, and some people in the study group said, why even ask if we know no one has it? Well, this is the baseline. This is what we're working from. Nobody has it. We said, okay, it's understandable. We just heard that there's very little awareness about NAFLD-NASH, but we do know that it's a common comorbid condition with obesity, cardiovascular disease, other liver diseases, diabetes, and so on. So we said, if you look on the left, does your country have a strategy or action plan for those conditions? And you'll see in the green that often almost half did. So if you had an obesity plan, if you had a diabetes plan, it would be natural for you to address NAFLD-NASH in it, even in passing. So the question was really, is NAFLD or NASH mentioned anywhere in this strategy or action plan, even as a footnote for consider this in the future? And you see the red here, that even where you have those strategies and action plans in place, this is the low-hanging fruit, no attention given to NAFLD-NASH. So that's really the first conclusion, that we need to engage more with those working in the comorbid conditions to raise awareness around NAFLD-NASH. We then asked something similar around having national clinical guidelines for the prevention, diagnosis, and treatment of NAFLD-NASH. And you'll see here the majority of countries said that they do not have clinical guidelines in place. That doesn't mean they don't know what to do or that they're not following international guidelines like the EASL guidelines, but they don't have national clinical guidelines. But they do for many other conditions. So similar to the strategies and action plans, we said if you have clinical disease guidelines for obesity or diabetes, hypertension, and so on, do you mention NAFLD-NASH? So on the left, most countries have these guidelines. You see the large amounts of green. And on the right, you see that most of them don't mention NAFLD-NASH at all, the large amount of red, except for maybe in liver transplant, which makes good sense since we just heard that NAFLD-NASH will be probably the leading cause of liver transplantation within the next 10 years. Around awareness, we asked the question of, do government-funded awareness campaigns in non-hospital clinic settings on healthy eating, healthy foods, physical activity, soft drink consumption, anything related to that, include any specific mention of any aspect of liver health? We worded that very carefully. We're really hoping to get a yes here, and yet most countries said no. We do all of these great campaigns around healthy eating and foods, but we don't mention liver health at all. That makes no sense. We asked if there are any in-country civil society groups focused on NAFLD. Teresa's here from the Catalan Association for the Study of the Liver, or patients group working with the liver. Many countries will have a patient group. Often they're more focused on viral hepatitis. and the reporting we had for largely focusing on NAFLD was that there are no patient groups or civil society groups largely focusing on this issue. Regarding monitoring and data, this is extremely important in the policy realm. Sometimes we say if it's not monitored, it really didn't happen, and there'll certainly be no action taken. So we asked, does your country have any national, so not a cohort or subnational, disease registry that includes NAFLD and NASH? Only Spain, Portugal, and Lithuania reported yes. We then asked if your country has any regional or national NAFLD-NASH cohorts. Countries did a little better, but still most countries didn't have national cohorts in place. There will be some subnational cohorts, but not a national cohort to understand what's happening at the national level. That's, again, extremely important when you're working with the European Commission and its specialized agencies dealing with health. They want to know what's happening at the national level. We asked, have there been any population-based epidemiological studies done to assess prevalence and incidence of NAFLD-NASH in your country? This is important. So if 2/3 of the countries, around 20 countries, said no, you start to wonder how reliable are our global estimates if there's been no national estimates done in the last 5 years. And that's why there's been a lot of important modeling done, but we actually know very little about the global or even the national prevalence. We asked if there are ongoing nationwide epi-studies, and a few more countries said, we don't have studies, but we do have some studies happening now. So I think in the next couple of years, we'll start to better understand the extent of this epidemic. Regarding prevention, testing, and diagnosis, we asked, do regional national policy guidelines specifically recommend screening of NAFLD-NASH in patients with either obesity or diabetes or metabolic syndrome? So this is indicator condition guided testing, similar to the work we did 10 years ago on HIV, when we found out that if you had tuberculosis, if you had viral hepatitis C, you weren't always being offered an HIV test, which made no sense. We then asked here, if you have obesity or diabetes, is there a recommendation to be screened? And most countries said no. And we'll be talking about this later, Rachel and others. I mean, when we go out to the public, to the GPs, to other areas, what's the message we want to give? And I think, the low-hanging fruit, the first steps are to make sure that our colleagues in diabetology, cardiology, working with obesity are offering or are looking at NAFLD-NASH in the patients they already have in their care. So this busy table basically just responds to the question of which healthcare provider is typically responsible for the care of NAFLD-NASH patients following diagnosis. So not surprisingly, gastroenterology, hepatology, often internal medicine, and to a much lesser extent, multidisciplinary teams. And that was what we were really trying to get at with this question, was to understand in how many settings are multidisciplinary teams addressing NAFLD-NASH. We'll hear in later talks from Shira Zelber and others that the response in the absence of treatment is really to promote structured lifestyle interventions, and this will require going beyond, with all respect, the hepatologists and the GE doctors, and bringing in dietitians, GPs, and others who are more familiar with that area. So we then asked, finally, are structured lifestyle programs aimed at NAFLD-NASH available? And that doesn't mean that a hepatologist or other specialist won't recommend it, but we wanted to know if really nationally there are structured lifestyle programs in place, and only a quarter of the country said that that was the case. So there will be examples where it's happening in countries that responded no, but it's not happening systematically. There are no programs officially in place. So, now we've seen a really, I think, abysmal policy situation related to NAFLD-NASH. A lot of the obvious relationships with comorbid conditions aren't being taken advantage of, and we're really working with NAFLD-NASH just in the area of liver disease, in hepatology, and so on. Probably many of you are familiar with the Sustainable Development Goals. Some of you might not be. These are the goals that were launched in 2015 with the idea of achieving them by 2030. They followed the Millennium Development Goals. In the Millennium Development Goals, there was very little attention given to non-communicable diseases at all. There were 8 goals. In the SDGs, there's 17 goals with almost 100 different measurable targets, and very broad goals set around no poverty, no hunger, having good health, having sustainable cities and communities. And we would situate NAFLD-NASH under good health, including positioning it in terms of universal health coverage. But I would argue that NAFLD-NASH, just as it's a comorbid condition, is really a sort of a co-goal condition. I think that we need to think about NAFLD-NASH in terms of poverty and hunger. We know that when people are hungry, they can't necessarily choose what they're going to eat, and they'll make unhealthy decisions regarding their diet. We'll often see obesity in people who are poor and not eating well, and that will be another area to look at with regards to NAFLD-NASH. NAFLD-NASH, we know, is not just a problem in high-income countries. We're giving it more attention, but studies are showing that it's also an issue in poor countries and among the poor. It's an issue that's related to inequalities. And I think goal 11 is important because it's around sustainable cities. We need to make sure that cities are fit for purpose, that cities allow us to walk and bike and exercise, all important ways to prevent and also treat NAFLD and NASH. And ultimately, goal 17 is around creating partnerships in general for the development agenda. And for us, and particularly at the EASL International Liver Foundation, it's important to develop a global partnership to address NAFLD-NASH moving forward. It's important to mention universal health coverage. This has been championed by the new Director General of the World Health Organization. Universal health coverage will determine the basket of goods, the minimum services that all countries should be providing to their population, and ensuring that there aren't excessive costs relating to accessing important health care. So there should be no financial hardship involved in maintaining a minimum good level of health. And I think it's important for us to look at how can we start to position NAFLD-NASH into the framework of universal health coverage. We've started engaging with the World Health Organization. There are a lot of other conditions in competition to be covered in universal health coverage, but I think we have a good argument because of the close relationship with obesity, diabetes, and so many of the other sustainable development goals beyond goal 3, which focuses on health. So in conclusion, NAFLD-NASH is a hidden epidemic with limited attention in health policies and clinical guidelines, particularly in non-liver fields. A comprehensive public health response to NAFLD is lacking in all 29 countries studied. This was 29 high-income European countries that are not comprehensively addressing NAFLD and NASH. And there are major gaps, including strategies, clinical guidelines, awareness, and education. And only 7 countries reported structured lifestyle programs aimed at NAFLD. 4 countries reported active collaboration with civil society groups on NAFLD issues. I think if we're going to change our approach, we're going to have to very much engage with those at risk of NAFLD-NASH and those already aware of it, the established community and patient groups. And finally, policy levers such as the Sustainable Development Goals and universal health coverage should be considered for raising the profile of NAFLD-NASH. This is our next horizon, how to get NAFLD-NASH into the international policy discourse. And one more thing. I mentioned at the beginning the importance of language around NAFL and NASH. Some people, not the clinicians, will use it interchangeably. They'll use it just with a slash between the two, and that might be enough in the beginning in terms of engaging with non-liver specialists or non-clinicians. But I'm going to show you now 2 slides around language, and I'm going to be looking at your facial expressions from the podium here. So next year we have a big meeting on hepatitis in Scotland, and one of the members of the organizing team there was mentioning that, well, you know, in Glasgow there's a lot of drinking, and that there were 50 words related to being drunk. And often when you look at this, you know, you think, given the problems in particularly Glasgow, you might have heard of the Glasgow effect, where people in Glasgow have a much lower, even a decade lower of life expectancy than the rest of Scotland, much of it related to alcohol and related issues, that when you read these, you think it's quite funny, you know, that there's plastered, guttered, blitzed, paralytic, so on and so forth. Even though it's such a serious issue, we can smile when we see these expressions for calling someone drunk in Glasgow. When we turn to obesity, none of these words are funny at all. For people who have a weight problem for whatever reason, to be called heavy, chubby, pudgy, hefty, flabby, meaty, etc., it's incredibly stigmatizing. It creates so much discrimination. And the stigma and discrimination related to obesity that then is linked to NAFLD and NASH has driven EASL and The Lancet together as a part of the upcoming commission that's being carried out to have a whole section on stigma and discrimination related to liver disease. And I think as clinicians, you'll see that one of the big challenges you have around non-alcoholic fatty liver disease is the wording itself. We're already talking, even if it's non-alcoholic, people hear alcohol, and even if it's a fatty liver, they hear fat. We already heard that maybe 10% of people with NAFL will have lean NAFL or lean NASH, but there's so many terms, and this is just in English. I imagine it's similar in other languages, and they're all negative related to being obese or being overweight. And we'll need to think very carefully about the terminology that's used. Just like with viral hepatitis, where we now talk about people who inject drugs or people who use drugs. I've been to clinical conferences where clinicians have said, in a very well-meaning way, that it's really important to treat all the junkies. And junkies is seen as a very negative way of referring to people who inject drugs, but they meant no harm by it. We'll need to think carefully about how we refer to obesity moving forward, especially as it's linked to NAFL and NASH. So on that, I'll close, and let me acknowledge the co-PIs of the study I presented, the members of the study group who helped develop the questionnaire, and all of the country leads who quite tediously went through the documents and reported back the situation in their country. I hope this study will be very out of date very soon. I'm not sure that that's going to be the case, but we are going to update it from 30 countries and expand it to 194 countries. We'll see how many we can even find someone who knows anything about NAFLD NASH in those countries, but we thought maybe we would focus on countries with a high prevalence of diabetes or obesity, or countries with high income, and the response was, don't leave behind the poorer countries, don't leave behind Africa. Even if you can't find anyone there, that's a finding, who can respond, that's a finding in and of itself, because as people are living longer, we'll start to see NAFL and NAFLD and NASH as a major issue for them as well. So thank you.